Yes, there was a correction that I had gone over with Jen. We were going to eliminate just one paragraph and change.
I duplicated a paragraph. I put Lakeview Gardens, if you look, I copied Cheryl's notes and I copied it twice. So if you look on the second page, I have Lakeview Gardens at the top, and then under Goose Lake Medical Services, Lakeview Gardens, I have that same paragraph with a typo. So instead of 132 residents in assisted living, we had 13. So I'm going to eliminate that top paragraph and fix the 13.
Wow, look at that.
Since it's down.
Yeah.
You and I both did.
I didn't know that capacity was that good.
Yeah, 132, yeah.
So I still move that we accept the consent agenda items as corrected.
Been moved and seconded to accept the consent agenda as corrected. All those in favor?
Aye.
Passes unanimously. The April 2019 LHD reports.
Yeah.
Got my glasses.
It is, but it's recording.
And Jake, if you didn't want to stick around, you could go home.
There's nothing
Unless
there.
you want to watch the recording.
I don't mind.
Okay.
Thank you. Are you trying to get rid of me?
No.
Okay, so April was a good month. There was 344 patients in the hospital. The average so far this year is 323. It's a little bit higher than last year. For the last 3 months, I think you will note, we have really been gaining. We kind of had a bit of a lull, and now we're gaining ground again, which I think is great. I added a couple of things. Where's my, I decided to expand this a little bit. I've added births to this. It doesn't add into this total because babies don't count as an inpatient or a hospital patient. I think mommy does. But, so that won't add up to the total there, Dawn, just so you know. This is everything except that. But anyway, I think the exciting and kind of cool thing is we are 54 babies this year. Last year, this time 57. That's a 45% increase, and there's like 6 ladies that are ready to go here, so it's kind of neat. This week.
I think, is it, or is it one?
Well, one was just born.
Right. Might be down to 5.
Well, it's fun, it's a cool thing. So, hospital is starting to catch up to last year. Ancillaries continue to be very, very strong. It was a good month for all of our ancillary services. You see lab, radiology, and rehab are up 8, 10, and 9%. That's big. Home health, it goes up and down. The health clinic is up a bit. The Alturas Health Clinic is up 22%, which is big. I mean, that's partly because we're not going to Canby, and it's also because we're focused on Mom doing a good job down there. And then I've added the wellness clinics to this sheet so you can see they've had a 22% increase year over year in the number of people they're seeing. So good numbers. Okay, gross patient charges for the month were $3,483,000. Here, our average is $3.2 million. That's a 10% increase year over year. Another very positive slide. Collections on AR. This is the best slide today. Here's March, here's April, and here's May. We just got done with May, so we know that May was 2.5 million, April 2.45, March 2.5. So this is excellent, and this is just about where it needs to be. We still need to see a little bit of improvement when I look at gross charges and our contractuals and how much we should be depositing. This is getting a whole lot closer to where it needs to be, and that's very good news.
What a difference between now and November.
Yes.
Good jobs.
Yes. And here's your days in AR. Here we topped out in January at 101. You see the steadily declining. At the end of May, we were at 74, which is here. Today, we're at 72, so we are, very, very good news, very positive, and keep it up, keep it up. Okay, getting motivated. We're gonna start expecting this, all right? Right?
The rate won't continue, just so you know.
To 60. If we want to get down to 45, so then if we go with new software, we'll have room to breathe, right? 60. Well, okay. All right, so then our days cash on hand went from 58 to 60. I wish that they went up as fast as the days in air went down, but they don't. So, however, it's moving in the right direction. If we could bring our expenses down, that would help this slide quite a bit. And that is, I think, what needs to be our next focus is, we've got our revenue at a good place, how can we get our expenses reduced? So anyway, for this is the month of April, this is actual budget prior April. So net operating revenue was 2.6 million, it's actually $34,000 over budget. Year to date, did I say that right? Yes. And compared to prior year, it was 787,000 more. Total expenses were $2.7 million, 30,000 over budget, 250,000 more than last year. Net gain was 111 for the month, which was 83,000 more than budget, and 585,000 more than last year at this time. Last April was not a good month.
Yes.
Yeah, I don't remember, but it wasn't good.
I don't remember April's, it's tax season.
Oh. Okay, and then this is our year-to-date comparing actual budget and prior year. I think that it is excellent that our revenue is 25, is only 178,000 below budget year-to-date, considering the fact that how much we had budgeted for an orthopedic surgeon. Ancillaries is making this up, and that's, this is obviously hugely helpful. $3.3 million more than billed last year this time. Total expenses are $27,659,000, which is just 30,000 more than budgeted. $3 million more than last year at this time. That's a significant number also. So our net gain is 390,000, 116 over budget. Last year to date was 277,000. We're 112,000 better than last year. So good news. Nice to report this. Balance sheet, really no changes. Cash went up and AR went down. Haven't really paid money out to Adroit and haven't borrowed on the bond, so no big changes in debt. So really month to month, almost nothing happened. And that's it for the hospital. Questions on that?
Yeah,
Okay.
just keep it going forward. That's the trends we like.
Yes.
We work hard at that. Okay, so this is Lakeview Gardens, just for long-term care. They had 539 patient days, which is about 17 patients. Their revenue for the month was 176,000, sorry. And then, so that's just long-term care. And this is assisted living, just assisted living. They had 360 patient days, which is about 12 patients, dental and staple. The net addition of days overall between the two of them collectively is 860 days, and their revenue for the month was $41,000. And then combining the two, April's net revenue was $212,000, expenses $292,000, so we had a loss of $80,000. That's really close to where we need it to be, where we budgeted for it to be, so that's good. We are still $395,000 worse than last year, but it's been getting better. It's been better, and the balance sheet really, no change to the balance sheet. Because it won't ever change because they really don't own anything. So they don't own anything, and they don't incur debt except to the hospital. Questions? So, a good month. Lake Health Medical Supply, they went live on their new software called Brightree in this week. I think it's going pretty well. They had a good month with 35,000 in sales and 8,000 in profit. They're just kind of nice and steady, so Brightree, hopefully this is not going to cause a big gap in billing and cash flow. Time moves out. But I would expect it to pause a little, because it does when you get new software. Okay, that's it.
The number of customers kind of stayed the same.
At this point, it is really kind of staying the same, because I think, kind of, we grew and grew and grew with the oxygen patients, and we've kind of leveled off with them. I think one of our, I might have to talk to Quentin and Brian, but one of our biggest opportunities for growth is to get more sleep lab patients, because we're so far behind, and when we have a second sleep lab person, we see our DME sales for the equipment you need go up. And I think that's our next opportunity. But we have kind of leveled off as far as oxygen patients. And we've got a big lion's share of the patients in Lakeview.
What we also elected to do is not to expand more heavily in California until we went through these changes. So we wanted to pause, make sure we made the changes that were recommended by the consultant, including this change in software. And then once we get that settled, then we could expand more in California.
Okay, so moving on.
Yes, moving on.
The budget.
The budget.
With the budget approval.
Everybody, of course, has memorized the budget.
You remember, I brought more copies in case you want to look at it again. We haven't discovered anything new that makes us want to change the budget since the budget meeting. You were all there, so, if you have any questions, let me know, but otherwise, kind of the same old, the same budget, aggressive as far as revenue and savings, includes a software rollout. And I would say the only changes possibly, our software proposal is a little bit, Charlie haggled them really hard and they pushed the cash flow out a little bit, so that will help us. That's the only change. See if we can change the budget that I've got to consider. Anything else you want to add?
Recommend that we table.
Oh, well, yeah, of course I recommend it to approve it.
So move.
Second.
Been moved and seconded to approve the budget as it was presented. All those in favor?
Aye.
Passes unanimously.
I would like to make a comment, Cheryl. I thought it was well presented this year. I thought the format was improved.
Yeah,
I
good.
liked it much better.
And that was a lot of Joey. Joey really did a
Nice
lot of
job.
work on the budget, and he did do a good job.
Yeah, you did.
Yeah, thank you.
Okay. Mr. Twait, the construction update.
Okay. First part is our clinic remodel status. We have received most of our bills from Adroit. We're waiting on some final adjustments. We did just get in their latest, and they don't think they have much left of work to do on the project. One portion, well, there's a couple things that are still unfinished. One is all of the door frames, when they were ordered white, not gray. Nobody knows quite why. And so we painted the door frames gray. Every time somebody touches them or hits them with a wheelchair or something, it nicks them. The solution is really ridiculous, but would be to pull out all the door frames and put it into white or gray paint at the factory door frames. Rather than do that, the next best solution is to put little guards and little strips along the edge wherever those might occur. And it's been done in many other locations, and so we've agreed to do that. They're ready to, just about ready to do that. So that, and when we built the front door into the clinics, we said 30, the architect designed 36 inches. Fortunately, our bariatric wheelchairs are 35 inches. So anytime somebody wheels a patient through the door that's in a bariatric wheelchair, it's really tight. We got an estimate to replace the door frame with a 40-inch door, 42-inch. We haven't quite decided whether we want to spend that kind of money to change out that door frame. Those are the two things that are going on there. So it's virtually complete. We do have a little bit of an issue out in the Lakeview Gardens. Two things have come up. One is we did not put in backup water heaters. We thought that the geothermal heat process would adequately work. We have had a couple instances where we have been without water. And there's been something where the pump didn't work out at the well, or just last week we had a break in the system, not on our campus, it was another location. So we do not have it in our budget. We didn't think we would need it when we built the building. But for $15,500, we can get 3 backup water heaters in the gardens. So I would like to have approval to move ahead with buying those backup water heaters so that if it were to happen where it's in the middle of the winter and the geothermal goes out for some reason, we have hot water available for showering and that kind of thing.
That's installed.
That is installed, is about $600 in electrical connecting for it. But yes, that's installed.
Just out of curiosity, Charlie, how long are we at down with hot water when the geothermal doesn't have something happen?
One just this past week was for maybe 24 hours. Could be longer if the issue was resolved. I think when the pump went out, when was that? Fall or early December, I think it was maybe down for a day.
And does the town do that maintenance?
Oh, yeah, I mean, they're responsible to fix it, they got on it, but remember, we still have patients to take care of.
Sure.
And we thought it would be, not like foolproof, we just didn't think we would need it. We just don't feel comfortable not having those hot water heaters. So I'm recommending that we go ahead and make that investment now. The system's not that old, but, you know, the whole line has been in for 8 years, is that right? Sound about right, Derek?
8 years. There was a test saddle on the pipe that blew off this last night. So it took, I don't know, the town had it fixed by about 2 o'clock in the afternoon.
So it's not like it can't, it's not like we're going for extended time period. But if we don't have hot water at that time and we need to bathe the patient or we need to deliver care, it's probably not in our best interest to not be able to deliver that service.
I so move we accept Charlie's recommendation.
I'll second it.
Been moved and seconded to approve the backup water heater purchase as presented. All those in favor?
Aye.
Thank you.
Passes.
Second thing that has happened recently at the garden, this is concerning for all of us, and we have the engineers and architects working on it. The lights on the outside, they were designed to withstand the winds, and we had one of them fall off. It actually broke from the wind. So we have manufactured
Parking lot lights.
parking lot lights. So you can imagine a 30-plus pound light falling. It's not supposed to do that, so we're working on that. But you needed to know that we are addressing that. So I don't think that that's going to be,
That would be a warranty item, wouldn't it?
oh, yes. But we have, since that occurrence, we have shored up the lights so that if they were to break, they won't drop. We've done that, but we're still working through the contractor and the manufacturer to make sure that's right. So now I think it's time to talk about our EMS building. We have Daryl here to help in this process. Daryl, do you want me to make the presentation, or do you want to talk about it?
I can talk. Anybody wants to listen. The bid opening was today on the EMS building. Since we started working on it late last winter, working with ambulance personnel, it was a little bit of a project to get it within what we thought we could afford. Our budget was somewhere around 2.25 million, 2.3 million. We decided, once we started into this project, I kind of decided to hard bid it instead of going with a general contractor management like we've done on several of the other projects. I thought it'd be a little cheaper. And I think, yeah, it did turn out that way. It was a little more work, but the bids we received to date, Charlie passed them out. You have the bid
Yeah,
No,
out.
let's put the bid-
not
let's put the
the
bid-
just an analysis of the total.
I have the bid, we'll put it up here in a second. It should be under the...
Done.
Yep.
Well, that's helpful.
There we go. We had three bidders. Adroit, of course, bid it again. Kinsman from Klamath Falls, and Rob Thornton bid it also. So the bids were pretty close. I was pleased about that. Kinsman is the low bidder at 1.225 for the building and the related site work. The bids were in order. You see all the other required data down at the bottom that they had to submit. The building is a metal building. It's a bare bones building. Park 4 ambulances, has some office areas and a little bit of a sleeping area up above the office area. The floor is heated with geothermal heat. The cooling and backup heating to the office areas is via heat pump. So it's a pretty bare bones project. We left as much out of it as we could to have a functional building. The ambulance people said they were going to do the interior painting. That's not in the contracts. That's not in the contract. Some of the finished work isn't quite completed in the upstairs area. There's sheetrock on the walls, painted lights are in, plugs are in, that sort of thing is in. But it'll be a nice facility for them, better than they have basically nothing now.
So what have the ambulance crew, disaster unit agreed to do in addition to what we have here, aside from painting?
Well,
Finishing?
the only thing I can talk to is the painting, because I left that out of the finish schedule. There's no appliances in there. There's no refrigerator, there's no stove in the kitchen. The kitchen is just a residential type kitchen, it's not a commercial kitchen. And the special washer that they have for throwing all their turnouts and clothes in, whatnot, that is not included.
Is the plumbing in there for
The
that?
plumbing is in there, yeah, the electrical circuits are in there for it. Those are the three.
Disaster unit crew is aware of these things?
They're aware of those things, yeah.
Okay.
That's the only things I know for sure, yeah.
Okay.
The rest of it, I can't speak for the disaster people.
Is the driveway included, or the parking?
Yeah, the site work, the asphalt, the concrete, the two aprons in front of the large doors are heated with geothermal water. the electrical connections, the service from the power company. Yeah, it's a functional building.
Okay. Nothing about landscaping or
No,
anything?
I don't have landscaping in there. And I don't have any exterior lights. I have exterior lights on the building. I have no exterior lights on the parking lot.
Can we build it that way, with
Mhm.
the city's approval?
Mhm.
Okay.
Charlie and I worked on it after the bid opening. Charlie came up with some numbers, and I came up with some numbers of some other costs that aren't included in the contractor's bid that we'll have to pay for.
So
Do you
what
have
we,
those?
yeah,
Yeah.
everyone has a copy of what, the only difference between what Darrell gave, he's got a little more detail on it. That's the numbers you gave.
Okay.
Did you need an extra copy?
Yes. Otherwise, Judy.
And Judy's out of here anyway.
But I'm interested.
If you go down to underneath the cost, of course, we have the base construction, which is Kinsman's bid. I included a construction contingency of 5%. Charlie wanted to include 10, 10's fine. If you want to put 10 in there. We have a bare site. I'm okay with the 5. Basin Telecom does your work in the hospital. So that's for the door locks, the internet drops, the phones, and the video surveillance cameras in the building. So that number is their cost to put that into the building. It was not included in the construction bids. The only thing that was included in the construction bids was the conduit to run those low voltage circuits. So
We did that because in each of both the gardens as well as in the clinic expansion, Basin Telecom has been able to integrate our alarm system, so it's all in the same system, our telephone system, so all of the telephones are through our main telephone switch, our badging system, all those kinds of things. We have one vendor installing it and maintaining it, we get better consistency. Okay?
I couldn't really list Basin Telecom as a sole source in the public bids. Plan review permit fee, the contractor is responsible for mechanical permits, electrical permits, but the initial permit fee and plan review, we have that, covering that. The power company fee is connecting the primary service and the transformer costs. The contractor is responsible for putting in the conduit and the transformer bolts. I got that fee updated today. One thing on Basin Telecom, they're handling just those things I mentioned. Now the 911 connection from the 911 center will be done by Day Wireless because they handle the 911 stuff within the 911 center uptown. So I left that cost out because the ambulance told me they would pay for that. It's about $20,000. So the contractor in the hard bid is running the conduits for that. All that will, Day Wireless will put the speakers in the rooms for the alarm system when it goes off. The alarm system shuts off everything in the kitchen when it goes off in case they have a stove on or whatever. So it does not open the doors. Because I don't think this building's going to be manned all the time, so I didn't want the doors to go off. We did not include a backup generator in the bid. The building should have one. Ironically, we could not find a code reference that it had to have one, but it should have one. That's $35,000.
And Darrell, the reason we didn't want to connect it to the hospital backup generator?
I just felt that was going to get too complicated and too much cost. It's not a very big generator to run this building. only 100 kW, so it's not very big. So it can have its own standalone system.
Is that something you might get a grant for?
Conceivable. It's conceivable. We have not approached any granting until we got some estimates and our firm bids. These last few items we have, it's a combination of estimate and firm bid.
And some engineering costs, I guess we came up with remaining amount of $687,000, 366. I got the funding numbers from Charlie, so other than that, I don't know much about funding.
So what's the expectation, excuse me, that, who pays for the items that are left out?
The way we would look at that is it would be the district's responsibility to pay for it. We have to look at the funding sources. So we have received the gift of $500,000, and the Lakeview Disaster Unit has given us, and I think I provided a copy to all of you, of a $250,000 grant. So that's the $750,000. The difference we would borrow. So we want to go through
Which
that.
is the 687, about.
Give us-
But I'm talking about,
You talked about the additional items
I
not
am,
included.
that are not included in here, like Darrell just mentioned, the 911 wiring, the washing machine,
EMS.
the paint, the
The
EMS.
disaster unit
They will pay for
has
those?
said that, excuse me. I didn't mean to speak over you.
No, you're fine, go ahead.
The disaster unit has said that they would provide it. Now, I don't have that in writing as of this moment. They have verbally given that assurance to Darrell. We would want to have that in writing, just to make sure that, at one point in time, they felt that they could take the unit that they have, the washing machine, from their existing location and relocate it. There's been a change in that thinking. I'm not sure if it's because of the age of the equipment or it wasn't worth moving or whatever the reason is. But they're saying that's part of it, something that they would do. Okay?
So while-
Landscaping, why did you eliminate that?
Why did I eliminate it?
Mhm.
I was just trying to get something functional. That was a good plan. No other reason for that.
It would be my expectation, if we're going to maintain the building, we're going to have to add those items in. So there's going to be some other expenses. Because if it's on our campus, we got to mow the lawn. Even if we're not mowing, somebody's got to water, you're going to have weeds, and you have to maintain this. And we want our campus to be a consistent, good-looking facility.
Yes.
So there, I don't know how many other items like that might occur. We have planned to put lighting over where the employee parking space is. We were waiting till we get this before we set up those posts. So we will, but those are some of the things that as a district we will be responsible to doing.
So your loan capabilities are what?
Okay, I'd like to show you that. Can you pull up that other document? I didn't share this with you on the clinic remodel, and I apologize. This shows you how we got, how they, Adroit got to the numbers exactly of their construction.
No, down status. Okay,
Oh.
right.
That's it.
Okay.
So this goes through every line item of change during the construction of the clinic remodel. And so, as you can see, item 55 was the change as of February 28, 2019, modifications. So when we come up with this estimate, those are the hard numbers of how, from the original construction project that gave us the cost, any modifications to that. And we went through this in partial format throughout the construction project. These are the change orders, okay? I just want to remind you, because that is the latest information. Adroit gave us, this was,
Question, Charlie?
yes, sir.
These change orders, were they covered by the contingency figure that was estimated?
Some things were adds and there were deletes. Some items, so when you look at the very top, you'll see where we added in under line item number 5. And that was in November 2019. We added the additional siding for $155,000. But then above that, the $85,000 for the alternative list for the buyout adjustments. So there were some, and then we had some changes in the roofing. So this is during the construction process, the changes that were made, mostly it's additions. And then at the end of the day, when we compare, they had, so they originally estimated. Yes, do you have the whole So as of today, their original estimate was for, not estimate, the original contract was $5,219,766. Then there were credits of $153,148,000 with some adjustments, so the final came out to $5,066,618. That was the construction cost. So if they took that and the Lakeview Gardens project of $8,460,000, they felt they had $473,110 in borrowing of the $14 million. That was their estimate, okay? That's what Adroit provided us. Now, our numbers are a little different. So Cheryl asked Washington Federal, where did we stand with our project? And what this says is, as of June 4th, so 2 days ago, there was $146,695 remaining to borrow on the clinic project. Adroit had estimated that the two things that are still outstanding from their viewpoint of the project is, number one, the parking lot to the west of the clinics. Remember, we pulled that out. They were hoping if we got the project done quicker, there would be money left over. They estimated $130,000 to put in that parking. Okay. The other estimate that they have is for putting in the replacement signs. We still haven't done that. We're waiting for better weather. That is roughly $19,000, just about $20,000 to put in the new signs out front of the hospital direction. You know, right now, when you look at our signs, it says long-term care, you go to the right, when in fact you go to the left for Lakeview Gardens. So, that was where that money would come out of that first phase. Based on that, we have borrowing capability for the ambulance fund of $937,298. If you add in that 146 from the clinic remodeling and the interest, Washington Federal has stated is that our borrowing capability on that $14 million bond is that it has to, we have up to $1,085,000. So what that says is, based on the estimates that we got of a total of $1,437,866, including a 5% contingency, where I thought maybe we put in 10, because there might be other things besides sprinklers that aren't terribly expensive that might come up. So even if you use the number of 687,866, we do have the capacity to borrow on this project. Now, there is a challenge that we have to keep in mind. project has to be completed before the end of this calendar year.
I was going to ask Darrell that question. Darrell, do you think it'll be completed before the end of the year?
We have that date in the contract, the contractor's bid on it. I've had some concerns from them that they can't get the building delivered quick enough from the manufacturer. I don't know. I think it's gonna be tight. One contractor said he was not gonna have trouble. I don't know, just have to see. But
What Kinsman said when they gave us their, because they were present during the opening, is this is going to be next to impossible. But we gotta get something going right away. If we're gonna do this, we need to let them know so that they get moving on it.
So what happens if we let the contract to Kinsman and he's unable to meet that deadline?
So I asked the bank what would happen if there is still construction going on in December. Because frankly, they're not going to work from December 15 on. So they really need to have the project finished before that. And what the bank said is, if you purchase the opinion from the bond council, you probably could get them to extend. But it would require a change in the bond itself. Washington Federal indicated that they probably would not be overly concerned, but it would still have to require for the document to be changed. And we'd have to pay for it. So you can guess it'll be a $10,000 legal fee.
And what sort of a timeline is that? How long does it take to do something like that?
With the money, they can get to it pretty quick. So it's not that it's not inconceivable it could be done. I certainly wouldn't tell the contractor that. But
What did the other two bidders say about?
same thing. They're anxious about the timeline. They're not sure that it can be accomplished, but as Darrell said, it's in the contract, they have to do it.
And if they don't, what happens in reality, Darrell?
there's liquidated damages in the contract if they don't perform. You know, if it's out of their control, of course, there's some subject for interpretation there, but there is liquidated damages in the contract as it was put out to bid.
Is there a possibility in a situation like that now how do I say this, that by the 15th of December, you know it's not going to be finished, can you borrow as much money as you need at that point? You see what I'm saying?
Well, here's the challenge. In order for us to get a bond payment, we have to have the independent engineer, architect, come in and validate the work that was accomplished based on the billing. So now it's possible that might be a solution that if Washington Federal agreed to, that could be done. I didn't ask them that.
So if you maybe got 90% of the project complete and certified and paid for, but there's 10% to finish it, and your bond counsel or what have makes it too difficult, could you finish it with outside monies?
10% of a $1.4 million project. It's a lot of money.
Yeah, but I mean,
Could we do that?
could we
project?
borrow short term somewhere or whatever we had to do outside of the bond itself? Even though we didn't use the whole bond, but we just ran out of time.
I think I would be talking to the bank in October and November. If I felt that if the contractor says, I'm anxious, I don't think,
But as far as using the bond money, and we hit the cutoff and didn't have it finished, could we stop and still keep the bond money that we borrowed? I mean, does that make sense? if you borrowed it, hey, I don't know how you're gonna hand it back to them.
That's a question we could ask Washington Federal. I don't know the answer to it. There are stipulations within the bond that every time we ask for an advance or any payment for services rendered, we have to get the legal opinion every time we do that. That might be part of the advice we ask for. I mean, that's a requirement for having Washington Federal issue payment for that. So those are questions we could ask in advance. We've asked them already once, and they said, talk to bond counsel. I have not gotten an opinion or an estimate of what the cost would be for an opinion on something like this. But we could get that by asking.
You know, Charlie, it seems to me like in the experiences that we've had in construction, while being on, that we had since I've been on this board, we never meet a deadline. We're always over a deadline. We're never finished on time. So from my point of view, I think it's pretty safe to say we won't meet this deadline either.
However, we've always started at the wrong time of year.
We've
We've always been
yeah.
going into winter,
So-
coming out of winter.
I think we need to be very conscientious of that with the decision that's made, because ultimately, I would assume what isn't paid, the hospital, the health district will pay for.
Out of non-bond.
Not on bond money, exactly, exactly.
Daryl, how rapidly would Kinsman start?
Well, he has to order the building first, so
Right.
that would be the first thing he would do. And I assume he would do that as soon as we gave him a notice of award. So
Of course, there's site preparation.
there's site preparation and things that'll go on all summer, utilities, power, that sort of thing. And then once the building's delivered, then we can start putting it up. So, the bids are good for 30 days. We have,
We don't have 30 days.
you don't have 30 days, so, if we're gonna award it, I recommend we award it, get started with it. See if we can do the best we can on that deadline.
Yeah, so if we don't make the deadline, the downside is a $10,000 long-term fee. That's the downside.
And you still don't have that assurance with that.
Plus we go out to the contractor too.
Yeah, that's true. If the contractor's willing to agree to that, I'm in favor of getting moving myself.
It's my recommendation to the board that we move forward on this project. I know it's cutting it very close, certainly frustrated with the process. It's taken longer than I expected, but I think it will benefit our community. We have two very significant grants to help make this project work. We have, per the bank's documents, enough money in our borrowing capacity to do this. I think in the long run, for the benefit of the community, this is a project to do. That's my recommendation to the board.
Discussion?
Well, there's that, and I don't disagree with any of that, Charlie, but what I look at is what risk factor are we talking about as far as monetary? My experience is the same as Judy's. It doesn't get finished on time and it costs more. And you put those two factors in there, and we have to decide, are we willing to accept whatever financial risk that is? And to me, I'm not really sure that I have a grasp of that, what that worst-case scenario might be.
What's the liquidated damage dollars we're talking about?
No, I didn't bring a copy of the contract. I apologize. And I can't remember. I mean, they're not huge. You know, they'll get the contractor's attention. I'm sure he's seen that in the contract, so. But they're not huge. I mean, I'm not, I'll say something and they're probably not wrong, but I'm sure they're $750,000 a day.
$750,000.
$750 a day.
Oh, 7.
To 1,000,
Okay.
like $1,000 a day.
Okay,
Yeah.
well, that's better.
I wasn't understanding that either.
I'm sorry. This project,
Is also another way that we could approach this, to assure us that we have enough cash to do this. And that is to use the bond money first, and not use the grant money.
Correct.
Until such time as the project's done. And if the project goes a little bit further, we've already used the bond money, and we then use the grant money. Rather than use that first, we use that last. So if it does go past the January 1, or December 31st cutoff date, the cash issue is not the overwhelming issue.
Yeah, you're talking 50% of the project if you pay with the bond.
That's correct.
Up front. That's,
Well, that's a good solution.
I just want you to know
There
the
may
issue.
still be additional cost.
It's possible, but I think until we saw roughly what our capacity is and what our needs are, it is hard to predict. I mean, we're operating from just information of a couple hours ago, so sorry if I haven't thought through exactly this.
Daryl, in their reservation on getting the building, would they get it in time to at least spend half the project?
oh, I'm sure.
Yeah.
They're estimating they will get the building, the metal, in October. So if all the groundwork, all of the, everything else has been put together before then, the steel arrives. Does that sound about right, Darryl?
I heard 8 weeks to get the metal building. I heard 12 weeks to get the metal building.
So 12 weeks from now is
I
October.
don't know. I can't say that. Well, one thing I will point out though is, you know, we did decide to hard bid this project, so it's not a negotiated fee like you used on the other project. Because I'm not real sure you got your money's worth on the other projects. So the drawings are complete at this point. You're not completing drawings while you're building like you were on the other projects. So
Yeah, that's helpful.
can we have issues? Yes, we can have issues. It's a building project, but it's not, you know, there's not a lot of groundwork, there's nothing on the site, we're not going to find asbestos. Those kind of risks are, we don't have those kind of risks on this project.
okay, any further discussion?
Well, I think, I voiced my concern about it, but I think we're kind of under the gun about it. If we're going to do this EMS building right now, and not put it off at all, and use this money, which we have to use before the end of the calendar year, correct? We either do the project or we don't do the project.
That's correct.
Yep.
So,
So I'll make a motion that we proceed with the project as bid.
Okay.
to Kinsman, does that need to be in the motion?
Yeah, we awarded to the lowest priced bidder, which is Kinsman.
Been moved and seconded that we accept the award, or we award Kinsman the construction contract for the EMS building. All those in favor?
Aye.
Passes unanimously. It's easy to spend other people's money, isn't it?
I may come to the January 2020.
We'll give you a tour of the building.
Okay,
They'll all
good.
come.
You can help cut the ribbon, Judy.
All right.
Okay, medical staff privileging, and Dr. Hussey's not here. When you have the documents?
I do. And so I don't know if we sent out a copy of
Yes, you
it
did.
to both Dr. Watt and
Yes.
Dr. Smith.
Yes.
The medical staff met, recommended to the board of directors that you approve both of these applications. Dr. Smith, courtesy for family practice, and Dr. Watt, continuation of the courtesy.
I'll make a motion to approve. I'll second that.
Been moved and seconded to approve the medical staff privileging as presented. All those in favor?
Aye.
Passes unanimously.
Thank you.
Wow,
Nursing update.
you guys, are you tired? Do you need to take a break?
No, we want you to do your presentation because I can tell you're ready to go home to your side.
Yeah, I've been fighting with a cold cough thing for a couple weeks.
Yeah.
I'm winning though, so
I do
just.
it.
It's touch and go at times though. Well, really, I only just have one nice update for you all. You, as part of our capital equipment approval process, we purchased a new cardiac monitoring system for the central nurses station, as well as the ED and OB. Those will be installed somewhere around the first week of July. That's all on target. We have a lot of training to do, a lot of changes that have to be made along the way. It'll be a whole new system for us with new equipment to take people's blood pressures and look at their cardiac rhythms and all of that business. But that has, all those purchase orders have been done. And along with that, we were able to purchase a little add-on system that will go into the future cardiac rehab space. And we will be able to then do cardiac monitoring in that area as well with the same system. So that's just my little update for you this month.
Thank you.
Questions on that?
Amen. Excellent.
Yeah,
Thank you very much.
thank you. I hope you feel better.
Thank you.
Okay, EHR discussion, Mr. Clay.
That's it? Yeah, that's it.
Yeah, that is.
So, before we get fatigued, I want to talk a little bit about our EMS system. What happened? Who died? So, if you recall, it was in November of 2017, I talked about how I'd like to have a proposal to the board by September of 2018. Here it is, June of 2019. It's not because it has been a simple process. So what I'd like to do is talk a little bit about what has been going on for the last 18 months, 16 months, and what the issues are as we think about this. Well, we currently have our principal five software systems. CPSI is what we use for our inpatient and ancillary departments. eClinical is what we are using in our medical offices, both in the rural health clinic here, the specialty clinic, and the clinic in El Terrace. Home health, we elected not to purchase the CPSI software because doesn't make sense. It would cost us a couple $1,000s per patient because we only have so many in a given year. And that's what is the cost of the software. So they're paying that. We use the T system in our emergency department. In long-term care, we use point-click care. That's also used in the assisted living. And then we use the Credible software program that they had when we took over that from the county and is used in behavioral health. Those 5 systems are, in and of themselves, not exactly the best, but they are working. A big problem that we face, and Don can readily speak to, as well to our auditors, is each one has different billing information, and we can't get revenue information. It's really hard to tie in. Part of our reason for the delays in our audits and our cost reporting is because they can't make it work just right. So the term we use is silo. We also have these other software programs that you can see that we have there. So as we look at these systems, our principal focus for looking at a replacement electronic health record are 2 things, principally. If we're looking for a system that we want to stay with for the next 7 to 10 years, it's hard to predict beyond that. Number 1, we want to have ourselves better. And by that means we need to have integrated within our enterprise. We have a lot of different cohorts, which we didn't have when we first started with CPSI. Those of you that were here or not here, part of the reason why we chose CPSI is because other vendors were, at that time, our doctors were not at all on an electronic health record. And we were hoping that if we bought a system that was compatible with another physician practice system, they might choose that. Turns out neither one of them chose CPSI because the clinic system didn't work very well. We tried it, but we had a hard time. So principle number 1 is to make sure that our system operates our organization, Lake Health District, our entities, talks together. The second part is to make sure that we can, wherever possible, talk with the other healthcare entities that we work with. So when a doctor here wants to transfer a patient, it's easy to send information to another hospital and at the same time get information back. It helps in the care of the patient and the doctor. So when we started this project, well, that worked well. So when we looked at, before I go to that, let me go back to this one. I did something wrong. Can you get to the slideshow? What we looked at were 5 principal software companies. CPSI, because CPSI has changed a fair amount since we first got them. But they've changed with us, but they have more products. Their emergency room software has gotten better. Do we need to can we replace it? The second thing we looked at was we looked at Epic, because in the state of Oregon, 60-70% of all the hospitals, possibly even more, are currently on an Epic flavored system. Then we looked at Athena. Dr. Graham uses the Athena software. We looked at Cerner, and we looked at Meditech. Those are the 5 companies that we talked about. As we began to look at these systems, and we tried to use, to be as comprehensive as we could in looking at those, so I put the side right.
There.
Okay. So, like I said, these are the 5 main systems, plus these other software programs. For example, TrueCode is what we use to do the charting in medical records. Or Dr. First is what we use to connect with some of the, in the emergency room. So it's a connectivity issue. In the interfaces, so interfaces are EDI, which is, or PDMP. EDI stands for Emergency Department Information Exchange. It's a program based out of, it covers multiple states, and every time a patient presents to the emergency room, the doctor or the nurse can pull up if that patient had been to any other emergency room. And PDMP helps to bring up information about their prescription information. Omnicell is our drug dispensing system after hours or during the day. So we looked at these as options that we needed to, programs we needed to replace. This is the team that worked a great deal on looking at the different software programs. Now, we've talked about this off and on, but I think it's really important for you to know how much time and effort was placed in looking through the different options. We now are at a point where we think we have to make a recommendation. So when we look at, and I think everyone has tried very hard to be as fair-minded as they could. When we look at Epic, well, let me back into that. We looked at Athena, and the companies that have, or the hospitals that have gone to Athena, not just the clinics, doctors' offices, but the hospitals that have gone to Athena have very quickly gotten out. They have found that they're not delivering what they promised they're doing. So that immediately became an issue that we weren't sure would make a lot of sense. When we looked at Meditech, there aren't any hospitals, or there are maybe one in the entire state of Oregon that are using Meditech. So if you're looking at the systems that are predominantly available in the state, you want to try and be consistent. That's really two systems, Epic and Cerner. So when we looked at Epic, we looked at the proposal given to us by St. Charles. That was the first one, because Burns is the first organization to partner with St. Charles, the 4 hospitals there, and Burns is the 5th. We looked at the other hospitals that are like us that have participated or accessed Epic. Now, we're too small to get Epic on our own. It's just not possible. As an estimate, one vendor said, yes, you can get it directly, but it's $6 million up front. It didn't make sense for us to do. So we looked at the Epic through OHSU, we looked at the Epic through St. Charles, and we looked at the Epic through Providence. And each one had different pros and cons, but the basic reason that we had such a hard time with it is the software, while maybe really good, because you're not accessing it directly from Epic, you are reliant on that organization that you're getting it from. So what it really says is, if we're relying on St. Charles to deliver us care, we need to make sure St. Charles delivers a good service. Same thing with Providence. And based on our conversations with the hospitals that are either using St. Charles or that are using Providence, almost everyone said, and it's the users that said this, not just the administration, said that they struggled with timely response, with getting attention from that bigger organization. And they struggled with being held to the requirements of the bigger organization. So they were much less flexible than we felt, that our team felt was what we would want to do to ourselves. So based on that and the recommendations of this committee, we are recommending that we consider Cerner. If we go looking at what Cerner would do, this is the timeline from whenever we start. It's about 12 months. From when we come to an agreement until when it actually goes live. When we did this with CPSI, I think the timeline was about 9 months. So this is a pretty well organized process. They have articulated exactly when people would come here and what areas they would work on during that installation. process, and they have talked about who would go to their centers to see how their system works and what would be involved. And you pull up the PDF. It's
That one.
yeah. So this one, so
It's
let's.
horribly hard to read.
So the reason I wanted you to see this, go to the left and up to the top. So when you look at the different types of services, I don't want you to think about, we're not going to go through this. Not worth your time. But if you can scroll down a little bit, you'll start off with the clinical applications, the ambulatory applications, the revenue cycle applications, the billing information. There's, and then you can see in the next column over, the components that go into evaluating what this system would do. Now, it's true, Epic has a very similar kind of grid, but there's an enormous amount of information that goes into it, and that the team has spent a great deal of time trying to figure out what should be done, what should be included in this. Now, if you leave it right here, you'll, oops, I hit the wrong button. How do I get out of this? Yeah, that's really good. How do you point with this?
And then the center button.
Center button. Okay, so push the center button. So when we look at this, anatomic pathology, that's not included in the software. Why? Because we don't have a pathologist here all the time. So we don't need that. We did need, as part of the radiology, because the system doesn't, we have a current system with core. So we don't need those things. So that's why, as we've gone through each of the different items, and there's a lot of them, the team has spent an enormous amount of time. And everyone has said that they believe Cerner will be the best option.
So with Cerner, we stand alone?
Well, when it comes to asking for support, it is a direct relationship with Cerner. When we get into creating templates or creating components within how that software is used, we don't just get to choose anything. There are some restrictions on it, but by and large, the support is directly from Cerner. So, for all intents and purposes, it's directly from Cerner.
Charlie, that big list of different software that we currently use,
Yes,
how much of that is replaced or integrated into Cerner?
all of it.
All of it?
That is our goal. Now, there may be some that we might not be able to do, but we think we have it all.
So the financial reporting is integrated as well?
It's much, much better.
There are still some things we are still working on, even today, how, some of it is upgrading how we process, how we deliver, how we handle the information that we get. Whether or not it's linked in here or not. So presently, for example, I think a good one would be the fetal monitoring strips. Right now, if the doctor wants to find out how a patient is doing, they look at the strip to see what's going on. We believe and we expect that that will be able to be visualized on their laptop or desktop. So they don't physically, they could do it from home. They could be tracking the patient from off-site or in their office or whatever. So we think this will add a great deal of service to our physicians, which will make it easier for them to provide the service. Now, you've all heard the death by 1,000 clicks, and how physicians are not at all enamored with any software system. So when we talk with the physicians, this is going to be a great thing. Their answer is we hope it'll be a little bit better, but we don't really like any of it. The best option is to go back to paper, if we could do that.
it's a small issue, but it's expanded over the years I've been around, of reporting or analyzing what's going on in the hospital. I'm not talking about doctors' work, I'm talking about more and more reports of how safety is being done and this is being done. Do they have the reports you need?
They do. And so, for example, we have a couple of programs that we buy or we get that one is Light Beam through our ACO relationship, or Arcadia through our CCO relationship. Cerner has those population health tools. Which one will be the best, and do we need to buy it now, or do we use the existing that's already being paid for by the outside relationship, the CCO? We have to see how well it works. The experience with some of the other hospitals that I've talked to about their relationship for Epic, a hospital in Enterprise, they're connected through Providence to get their Epic, but because the Providence that they're connected to is in Washington State, the Washington State data is viewed differently than the Oregon data, which means that it doesn't work for them. So time and again, no matter how many times we look at other than Cerner, it's hard to find a reason not to go to recommend Cerner.
Who can we look at, or have you looked at, as far as hospitals that we know that use Cerner?
So the team went to a place outside of Kansas City. That was not something we knew. They looked at, that was one of their great facilities, and there were some good feelings and some questions. Then a portion of the team went to Astoria and looked at that hospital. Jane and I talked with their board members, and they talked pretty well about Astoria. What made Astoria a valuable site for the team to look at, and while it's not perfect, but it has good relationships and comparisons, they also have access to Epic because of their relationship with OHSU and the Night Cancer Facility at Astoria. And so they're able to look at both systems. Sometimes they say, I think it would be better to go with Epic, other times they say, I think it would be better to go with Cerner. Truth is, the people that say go with Cerner are the users. That's the nurses, the radiology people, or the rehab people, or others, not the management people. I think it's more important to listen to the people that are actually going to use the software.
Just out of curiosity, following up on Chuck's question, is there a hospital in Oregon that uses Cerner?
Oh, Astoria.
Oh, Astoria.
They do.
Only one?
There is another hospital, and that is in Coquille, I believe.
Oh,
But when we thought about going to see Coquille, what their administrator said was, we didn't listen to Cerner very well. And we installed it, and now we're having to pay them to come back and reinstall it because we screwed it up. So don't come and see us. So people have made, there are many, many stories of cringe at here, what you shouldn't and shouldn't. Did we do the cost? So when we look at the cost for the Cerner application as of this afternoon was, it's not on here? Okay. The latest one, and Cheryl made copies if you want to pass that.
I didn't, but
Okay.
I have one, I can pass it down.
Right, so it's $8.4 million over 10 years. When we looked at the cost from Providence, it's $10.2 million.
And what's our current cost?
So we're currently spending with all of this software about $600,000 a month, a year, is that correct? A year.
650.
$650,000. So the cost would bring us to about $700,000. Now, what Cheryl said I was able to, I asked if we could get some relief from Cerner, and they said they would provide us the first 6 months no payments. But they would have to come out remaining, instead of 120 months, 116 months, or 114 months. So there's not a true savings in terms of reduction, but they're just putting it off.
It's a cash flow.
It's like saving some
Yes,
cash.
That's a ton of money, isn't it?
Oh, it's a huge amount of money.
This
These
is enormous
systems are
amount of money.
huge.
Well,
And your big money is the IT personnel to operate it. I mean, the first year is gonna cost us dearly.
It
Because
is.
you're gonna run 2 systems.
You got to run 2 systems, and you're learning. In St. Charles, when they went live with their Epic the year before, they doubled their staff. And we're not planning to do that. So, when we saw the price for Providence, it solidified the recommendation that if we're going to do something, the best option that I can see is that we go with Cerner.
Charlie, talking to your Cerner, like Astoria, what did they say about their installation costs?
They all have different ways of describing how they count that cost. All of them define it as the cash out to Cerner. They don't talk about the staffing cost. So we can't get a good answer from it. So if you can't get a good answer, all we can do is compare the number that we have against the number that they've given us. And I wish I could say, oh yeah, we could say it's going to be this amount of money in labor costs. We've already spent a great deal of time and energy with staff going, studying this, working on it, hearing the presentations. So.
can you do the installation without additional staff?
Well, we are working on, we are right now currently down one IT person. So Amy Thiel, who's a nurse that has been in our IT, we call informatics department. She took a job working in the wellness center, because she's working on her psychiatric nurse practitioner position. So we have a position open for that. We have some position, we have a person in mind for that. So I think we might staff up, bring up to where we were, but I don't know how, we'll have to see how it goes. We have not budgeted for it.
In your contract with Cerner, will they provide you with somebody on site for 6 months or something like that?
They have a very comprehensive breakdown of what they would provide in that process. And rather than talk about all the details they've done this installation multiple times. They have it pretty well organized. You saw the schedule. They have very specific, how many people would need to attend, how much of this. We have to rely on that. So what I would recommend that we do, because the contract is a 100-page document, and there's a lot to it. We haven't even seen the contract, actually. What most small hospitals are doing is engaging a consultant to help them review the contract. I talked to a consultant that helped St. Charles choose their system, and I'm validating what they would charge to provide advice through this contract, contacting process. Cerner has also provided us with names of hospitals that have recently agreed to work with Cerner and the firms that they're working with. I haven't talked to them yet, so I don't know what their fees are and who they are. What I would ask that you consider doing is, number one, consider approving going forward with this project. Consider going with Cerner. Give us the ability, we have a pretty good idea of what the costs are. There are still some features within the contract that I can't answer, but allow me and Cheryl and others of the team to go through the contract and negotiate the final portion of it. I don't think the cost is going to change dramatically. It'll be some of the components and how it's, if there are problems with software, there are a lot of issues within the contracting process. And then we move forward to get this started. I don't know if we can get it done to start July 1, but the time frame doesn't really change. What does matter for CERN is they have dates that they can pick based on when an agreement is signed. So when would that install be? It may be that they say there's a slot open for you in April of 2020. Therefore, the start date is really this date. Or it could be, no, you missed that date. We have another date, because they do this in a very organized fashion. We had the similar circumstance with CPSI when we went live with that. And what we did is we were able to choose, I believe it was January 2nd, was it? Oh, Teresa's live. Do you remember, Abby, if it was January 1st or January 2nd that we went live?
It was in the winter.
It was within the first 2 days or so of January. And we chose that because we had just moved into the hospital, and it was the easiest time to make the transition. Did it work out well? It was a pain. It will be.
You have the pain for the first year, then you'll start to get some of the benefits, which will help. How much did you budget for this year?
Cheryl, I think we budgeted 600 or 700,000 in cash.
And if you push the cash flow to 6 months, then you're probably okay.
Yeah, it helps a lot.
There still may be some things that, as we look at, we think we know we want that. We're fairly sure, but we may change our mind. There may be some modifications. It's hard to tell. It's still very, very new.
So these are reimbursable costs through Medicare? Okay.
Does Medicare still have steps that we have to meet?
We have met them since it started. They,
I hope.
in the original, thanks, Teresa.
You're great.
Go great. In the original, in 2012, 13, if we didn't meet the meaningful use requirements, or if we did meet it, then we got the full reimbursement quickly, so we didn't have to wait for our cash. Then they started saying, if you don't meet it, you're going to get a reduction in payments. We have met it every year, so we have not had any experience with reduction. And they're changing a little bit on that because they're using other incentive measures. So, I've talked with all of the doctors about this, and like I said, they aren't exactly enamored with any system, but they think this would be a good one. Dr. Foster, who did go to Kansas City to see how CERN worked, came back absolutely enamored with how well the system works and what its capabilities are. The others have said we'll work with it. Naturally, it's not going to be easy in the clinics, but the more data that we have, it'll, right now, we are really hamstringing our doctors. If a patient is admitted to long-term care, they can't access that patient information with any ease because they just don't have the access to it. It's just cumbersome for them.
Well, certainly, if you're looking at the long term, which we should be, it's time to make a change.
And no matter how much we looked at staying with CPSI and upgrading with the CPSI system, number one, they don't have a mental health module. They don't have a good clinic module. So again, you're getting a, if we go back to our original premises, which is to make us as best as we can be, we're shortchanging ourselves. And the cost isn't that much for us.
Well, I think Bruce, thanks to the team that put so much time and thought into this. I've had the chance to talk to certain people. Of course, didn't really know that much about the other products, but I think they've come up with a good decision. I'm certainly ready to go forward.
I can tell you, Chuck, when you asked the question about what kind of expense did they actually experience, one of the things that is always saddening for me to hear is when I ask my fellow CEOs, how do you like your system? And when they say, oh, it's going great. And then our staff asks their staff, and the answer is very different. It helps. It does not give me great confidence that I'm getting a fair answer. So to a large extent, I've kept myself out of being biased and not hearing all the information, but rather rely on the people that are actually going to use it, that it is going to have the greatest impact for them. And if we're going to ask them to continue to be as efficient as they can, taking care of patients, we should be relying on them. And I think they've done a very great job.
We've just been validating their system for a long time.
And yes, it is a long road. But if we're going to do this, I think there's a couple things to keep in mind. If we don't do it now, it's not going to get any cheaper, and we're going to have to make a choice later on. Even the big systems that use, well, another reason to consider this is all medical students that are coming out have used either Cerner or Epic. So they don't, when we tell them we have CPSI, they have to relearn the system. Which means they're not as efficient when they're starting out or if they're visiting practitioners. It's very cumbersome for them.
Doing the quick math on this, it looks like it's really going to cost the district about $920,000 a year, if I'm reading this right. Not initially, but it looks like we're paying $76,000 a month, starting
Yes, there you
in
go, yeah.
And that's
January.
because that number changed when we got 6 months of no payment for the first year.
Right, I see that.
Because before that, it was less, and we hadn't changed our numbers until they just provided that this afternoon. So I misspoke before. Yeah, it did go up because we did
It does,
postpone.
yeah, that's
in
what,
the first
anyway,
year.
that's what this reads.
Medicare cost you for it, will they accept just running a dual system pay for both at the same time?
After all, CMS really wants us to have the best information systems.
Yeah.
Yeah, sure.
Well, I personally feel that you've done your homework. We should move forward. And like you say, it's a contract of 100 pages, we better get somebody who knows what they're doing to help us.
It's one thing to get an attorney, it's another thing to get an attorney that knows how to read and understands the installation issues and the license issues and all the components that go with it. And again, we haven't seen the agreement. So what I would be asking for is, one, that you authorize us to go with CERN, allow us to negotiate the best. We think we've got a pretty good price, we think we're pretty close, but finalize the deal.
Any comments from our audience?
I just came in case anyone had any questions. Charlie's done a great job to speak to most of our bullet points.
I appreciate your coming.
What did he miss?
Thank you.
One of you guys.
I don't think he missed anything. For me, it maybe another hit home with the point that for this hospital to remain independent and for our providers to continue practicing medicine and caring for our patients the way we have grown to and like to, Cerner's the way to go. It really is.
That's really my biggest point also. In order for us to practice how we need to practice, Cerner's the choice. If we went with an Epic system, we would be forced to practice like Bend, and we're not Bend.
Okay. So I then entertain a motion to go forward with Charlie's recommendation. And crew worked so hard for us.
I'll make that motion.
I'll second it.
Okay. Been moved and seconded to go ahead with Charlie's and the crew's recommendation for the engaging an attorney for contract advice and going ahead with Cerner.
I'm not saying it's an attorney. It might be an attorney, it might be a contract negotiator. I don't know their exact skill set.
As amended. All those in favor?
Aye. Thank you.
You got your work cut out for you now.
Yeah.
Now the work begins.
Yep.
It's nice to have your comments. It really helps
Well, thank you.
as a board member to hear what you have to say about it.
Yeah. Yep.
Thank you.
Thank you very much.
Is the meeting over now?
Oh, no. No. Employee recognition, Mr. Quaid.
Always a great opportunity to acknowledge people that make a difference in our community and in our organization. And this month is no different. We are often surveyed by outside sources, outside organizations that look at how well we do. And time again, and I'll tell you in just a moment, we do very well. But you know, it takes a lot of work to do to get there. And we've been preparing for one inspection that has gotten us a little bit nervous. And I think we're doing a great job, not we, this individual who's staying on top. And that is Brian Lucas in our DME department. He's really done a great job, not only taking over the department that he was learning to do, but he really is stepping up. And we have our inspection between June 15 and August 15, and we're pretty well ready. So Brian Lucas is our employee. So, a couple things. Can I get into my...
Go right ahead to the employee CEO report.
Okay. We talked a little bit about the EMS building and the Lakeview Gardens with the lights. I need to tell you about something that we've been working on, and I'm not sure if I screwed up or not, but I'll certainly talk about this. We engaged the firm of CTA, that's the same architectural firm that designed the hospital, to help us look at 3 areas that we needed help on. One is our occupational therapy laboratory room that we're going to convert over in the, what now we call the West Wing. Second part was to look at our activities room for the swing bed patients. That's on the south end. And then the third is the emergency room department to remodel that. We came up with cost estimates and believe that we can get those projects done. Not the emergency department, but the occupational therapy room and the swing bed room to expand to meet the size that we need. When I contacted CTA to do the work, prepare all the documents, because we believe we could do the construction work ourselves. CTA said they couldn't do it. They had a real big project and they weren't able to. So I engaged, or I called a firm called PKA out of Portland. And their representative in the Bend area came down and looked at the space and I asked for a bid, and he misunderstood and started doing the work itself, preparing the documents. So it's not actual construction, we're not doing the work yet, but they are spending the money to do the architectural drawings so that we can get them to the state and get the projects done. The cost is for the rehab space was going to be $12,450, and the swing bed space for $18,000. When I got the bill, I called up and said, "What are you talking about? I thought you were going to give me a price." And he said, "I thought you said start." I said, "Well, that's not what we talked about." So they reduced their fees to $10,400 for the occupational therapy space and to $14,000 for the swing bed space. So they're architectural fees, it's not exactly capital expense. But in order to get these plans done, and we absolutely need that work, so we have the plans now, and it will be submitted to the state so that we can do the work ourselves. And we think the cost estimate by CTA was $50,000 for the occupational therapy space, it was $25,000 for occupational space and $50,000 for the swing bed space. If we do it with our own team, the cost would be significantly different than that. So,
Physically, you're just talking about extending the building, right, on the acute care?
no, on the occupational therapy space, those are the designs where we put in a working washing machine, working stove. They're not going to cook, but they're going to make sure they know how to use the tiles.
It's in the existing building.
It's in an existing patient
They're,
room.
excuse me, they're gonna cook,
Well, boil water or,
cook an egg, fry an egg, bake a cake.
okay. So there'll be a little bit, but you're not cooking a big meal or using that a great deal. In the swing bed space, what they're talking about doing is where we have the, on the very end of the hallway, we have an indent, they would square it up. And where the double doors is, that goes out to the parking space, they would move the double doors out underneath, so it's not underneath the overhang, but it would move it out to where that double doors is. That gives us enough space so that we can provide the activities that our swing bed patients require.
So you're not building more roof space.
So I don't necessarily need your approval, but I didn't want you to think that we were doing this without your knowledge.
I like the way you negotiate with them on their price.
Thank you. I will give you an update on our union activities in our executive session, but I can tell you that our next date of negotiations will be on June 28th, so in about 2 weeks. Dr. Wincoop, Walker Wincoop came here. Thank you all that participated in the interview process. We got a very nice thank you note from him, saying that he really appreciated coming. He stayed an extra night and enjoyed Lake County, so hopefully we'll get that put together. We are having, for new board members, a board orientation. We didn't do that in a coordinated fashion when the new board members came on. It seems Jane was the most current new board member, but so that will be on June 17th because it isn't required to have a public notice because they're not board members yet. So we'll have an opportunity to tour the facilities and learn a little bit more about what it means to be in a critical access hospital. So I think that'll be a little helpful. I thought you might find it interesting that we have, as you know, a 403B program for our employees, and we also have a money that the district puts in matching salary for each employee. I think it's worth knowing that in our 403B plan, this is what employees put in, we have $4,218,545 that employees have been putting in, and about 47% of our employees are participating. Walt Davis, who's our representative, I have charged him with getting 100% of our employees, and he's trying very hard to do that. For the other employees that we put in a portion of it, they become vested over time, that's $6,416,000 for a total of $10,634,000. I think it's important to know. That's a very important part for those people that work here and retire. And the more that we encourage that, I think it's a very healthy thing.
It's probably illegal for us to borrow from that fund.
That doesn't preclude employees from doing it, but no, that's not something we have the ability to do. Peter Wolf is our new Human Resources Director, and he will start on June 24.
What's his name, John?
Peter Wolf. And he'll be coming here from the Boise area. As you leave the building, if you look at the front entrance and the waiting space, please note the new bookcase that has been installed. This is a bookshelf, and it's meant to be like a library exchange. This was developed by Bobby Stratton on behalf, and it says in memory of Virginia Stratton. It was carved, what? Seninger, that's what I meant. I said it wrong. What was I saying? Never mind. One of the students, I think, is a freshman in the shop class building. So we hope to get pictures of that and get that in the paper, because that's a pretty exciting. And you'll see it's a very nice piece. Tuesday and Wednesday, Gerald, you will hear some extra noise by your house as we'll have some.
Gonna bring your dog to work?
Well, I don't have a dog in this fight, but we will have the Department of Corrections inmates working in that area by the creek, and they'll be thinning out the space, make a lot of noise, but it will help greatly in the event of fire that we've been talking about.
This started with the neighbor's request, actually.
When I talked about Brian getting prepared for our inspections, we had two in the last month. One just finished yesterday. That was the lab inspection. We also had a pharmacy inspection. Both came out very well, so they're glad to be proud on that. And I think that's all I have to say. I'm out of words. Any questions or anything I can address?
Any additional concerns? Hearing none, we'll go into executive session for RS 192-616, 2, recommended personnel, C, medical staff,